Добрый день, уважаемые коллеги.
Good day, dear colleagues. Allow me to welcome you at a session that is dedicated to Epi Surveillance for HIV in EECA region. And our session is dedicated to, again, Epi Surveillance for HIV, and that includes the discussion of questions that have been relevant over the past 3 years. And 3 years ago, we held our last conference. So the reports that we have here to listen are going to be of interest for all of you. And the questions that you may have should be addressed at the very end of the session, so we will allocate some time for Q&A session, but considering the fact that we have a large number of speakers, I suggest that we start, and I suggest that every report should be no longer than 12 minutes. And allow me to present our first speaker, that is Natalia Ladness, Senior Research Associate, Central Research Institute of Epidemiology of Rospotrebnadzor, and she will talk about epidemiology of HIV in countries of EECA.
Dear colleagues, I'm very happy to welcome you. I would like to make a review presentation, and I will just have 2 slides by UNAIDS, and also I would like to speak about other source information. I will speak about the Epidemiological HIV Center, about the WHO, and also I will try to present the data on the country. You may see the key estimates by UNAIDS, so it's different from the data published by the national sources. And according to that data in our region, so mostly these are male, so we have a total number of PLWH 1.7 million 2019. The new cases of HIV 170,000, and this is a new pandemic in this region. Incidence and prevalence coefficient is the highest because it started later on and continues to develop. Another characteristics of the region, according to UNAIDS, so here there are 99% of new cases of infection, and half of them for the key target groups. And the registration data is different according to the National Ministries of Healthcare of CIS in the region of Eastern Europe, Central Asia, and in publications of UNAIDS, some of the Central Europe countries are included with a few cases, and also the Baltic countries usually are not included into UNAIDS statistics, but sometimes they are also included, and I just limited myself to CIS countries and ESDC. So the registered cases, what is the difference from the estimations by UNAIDS? Starting from 2010, by 2020, this is preliminary data. The data for 2 countries, for Kazakhstan and Uzbekistan. And our colleagues will comment on that. So the data as of December was used and extrapolated for annual indicators. We have a considerable decrease in 2020 for the registered cases, and that's not surprising. In pandemic, we have less of tests. And well, just in general, if we are not taking into account the current situation, you see that aside from 2015, the number of new cases going down. And if you compare these numbers against 2020 and 2010, so in 2010 these numbers are similar to what we had in 2010. And if we looked at prevalence and incidence for 100 population, and two problematic countries is Russia, the green line, and Ukraine, and green, the red line. And the peak of indicators was, you see, Belarus is the light blue. Also in 2015-2016 had a high incidence, high prevalence, and the highest incidence rates were in Russia, Kazakhstan, and Belarus, and Moldavia, so as well. So coverage with tests and was growing. And if we look at 2019 data, they are quite reliable. So by 60% was the increase in the number of tests per 100,000 of population started from 2010, and by 13% the coverage decreased in 2020. And we should understand that the quality of these tested in 2020 was different, because the countries could not just massively test the most vulnerable groups of populations, and that was more convenient for elderly people who came to medical institutions. Some slides about Russian population. So we have also the foreigners. In most cases, these are CIS citizens, and over the last year, 2.5 million people had tests for HIV. Among the representatives from these countries, there is a decrease significant in the last year, 1.6 million of tests, and the number of new cases also decreased, and 1,600 new cases of infection, and less people came to Russia for earning something, for work, and for other reasons. So this is the share of CIS citizens or from neighboring countries. Most were citizens of Uzbekistan, Ukraine, and Tajikistan. So more than half of all of the cases of HIV were for these countries, and Armenia, Azerbaijan, Kyrgyzstan share was growing, and there were quite a big number of cases of HIV infection, despite the decrease in the number of tests. And in all of the years, for all, we found almost 39 cases of HIV in foreign citizens. Usually these are from neighboring countries, less from more faraway countries. And here you may see the countries with a significant share of HIV infected people: Uzbekistan, Tajikistan, Armenia. Up to 30% of the total number of registered cases in the country, so they were in Russia. So there is also a cross link here, but this is a resource for identifying new cases. As for Turkmenia, we have several thousands of cases every year. In 2020, over 10 new cases of HIV among citizens of this country were found, and Turkmenistan is not registering any cases officially in its territory. The mean age of these citizens was about 37 years. 1/3 of them were women. Most of them are men, which is well known as well. If we compare against Russian data, we also have a dramatic shift in the age split in Russia, and the gender split is the same, 40% women. And at the same time, in the year 2000 and in 2010, mostly we had it in young people. Now these are mostly people over 30, and 70% of the first cases at the age from 30 till 50. What are the reasons for the infections? According to European WHO and CDC, mention heterosexual contact as the main way of transmission. It is in line with the data published by the country, but the situation may be very different in countries. And in the next presentation, my colleague who will speak about the situation in her country. And we read the publication that also there are outbreaks among the drug users, and that's not so rare. It is also related to the change of the drugs used in the countries, and there will be a presentation about that. And Russian data is in the slide. In 2016, more than half among the new cases were of a heterosexual context, and in 2020 the ratio increased to get to 65%, and less now goes for the drug users. The medical care cascade, you saw that. It's important that we have lots of achievements, but they are far from the goals of 1990. According to UNAIDS, only 41% among people living with HIV have suppressed viral load, and there is a high mortality from AIDS in our region. And compared to 2020, there is no decrease, but there is an increase, and the mortality among women is growing, and this is a difference compared to other regions. And the last slide I would like to show you, based on my short presentation. Of course, I would like to give more information. So these are the typical pathogens. So the region is uneven, and we have HIV 1 subtype, subtype A6 in most of the countries of the region. This subtype can be found, but in Middle Asia, so the circulated recombinant form HG, and these are isolated pandemics that can develop by themselves. And even in Russia, when we have the citizens of neighboring countries, usually they have sexual contact with people from their region, and they are transmitted with the same type of virus circulating in their region. So this is the joint study about the incidence of HIV resistance and the onset of antiretroviral therapy. In most countries, it's 10% prevalence of resistance, but in 2 countries, so it's more than that. The situation is quite complicated, together with a big number of new cases of infection. We also have a complicated general situation. How about the conclusions? Of course, we have lots of successes in our region and tests, lots of advancements in prevention of vertical transmission, and we have still a growing number of new cases, 80K plus of new cases of infection. You remember that when we were adopting the declaration, so we were talking about 40,000 in our region, so we are not even getting closer to those numbers. The age of PLWH, the age is growing in this group, and most get infection in the heterosexual context, but still the growth of incidence among non-traditional sexual contexts is also growing, and I believe that we could expect a compensatory increase of incidence in the next 2 years. People who were infected, in any case, we will have to find them. What we did not do this year, we'll have to compensate for that. Thank you for your attention. Thank you very much, Natalia. There is nothing to comment because you covered all of the problems in our region that are really typical for practically all of the countries in the region. Thank you so much. I would like to give floor to our next speaker, Irina Petrenko. Irina Petrenko, Deputy Director of Kazakh Research Institute Dermatology and Infectious Disease Republic Kazakhstan System of Electronic Case Management of HIV used for HIV surveillance. Hello, dear colleagues, dear participants of the conference, and as our moderator already mentioned, I will provide information about electronic case management used in Kazakhstan. Well, the incidence of HIV has varied difficult factors, so that's why we are looking for IT solutions for that, and how to also process and record the data. To get reports, we developed and continue to develop, and we continue to improve different IT systems for that purpose. In this slide, you have the list of info systems that are currently used in Kazakhstan. And I would like to say that during development of this system, it's approval of the forms and the complete compliance of algorithm of work of medical workers to prevent and treat HIV, and also we have the standards for monitoring and the use of ID number to identify the person, which helps to do accounting not only for the number of tests but also for the people. I will not just stop and enumerate that. I would like to speak about these IT systems. First, this is the online registration and the national register of tested population. So this is the system to process data for all of the people tested in Kazakhstan, and it is used in 173 medical institutions. Now it's working in 2 regions. As an ID, the identification number is used. It helps to make the analysis of testing values, and also it helps to work with the data from different organizations. It cuts the time for medical referrals, filing, and also it gives the opportunity to make monitoring of analysis and tests of different groups that we are tracking. It provides for analysis of the number of tested people during different types of codes by diseases and age groups. So in this IT system has a referral, as I've mentioned, and the referral for blood assay, and the diagnosis, and the medical institutions, they create in the register one referral, and so they can be combined. If the medical institution doesn't have internet, so these are some just far away locations, or it's in the prison, and the negative results are entered into the register, and the medical institution can give that result. If the result is positive, they confirm this test result, and they enter this information, and this database integrated with the next database. I will speak about that. This is electronic tracking system, so it's automatically integrated into this system. So we can get from this database different information materials with a split by medical institution, age, and so on, so we can clearly track coverage of the population without repetition. And electronic tracking system, which contains all of the epidemiological data, lab and clinical data, and it makes possible to get. Also in this system we can use different variables for reports in different territories, and also you can use different data in PDF and so on. And being a Republican organization, so we can make an analysis of all of the activities and how the epidemiological work, and we can also assess the efficacy of the work of our specialists. I wanted to briefly explain about our system. So there is the medical record with the medical demographical data, ART data, lab tests, and there is a module for ART, and the tools are different lists and registers and so on. Here you may see the screenshot from this program. And you can also make some calculations, and you can visualize the data for CD4, viral load and trends, and you can also assess the efficacy of ART. And then here we have the module of account and forecasting, antiretrovirals. It's in place in all of the HIV centers, and also we track their consumption, and we can use the scan, and this accounting provides for a control and of the possibility of ART when the ART medicines are given from one region to another. If that is the case, or it provides for automatic calculation of the consumption time based on prescriptions and current level of consumption, and the control of stocks at the warehouse, and other opportunities given by the IT system. So this is for patronage medical nurses to be used at tablets during nursing care at home. At the previous session there was ICAP representative. He's in charge of that system, and he spoke about its efficacy. We have this system in 3 regions, and it helps medical nurses to improve the medical care. It simplifies it, cuts the time for preparation of different documents. And also I think that this mobile app has very good prospects, and I would like this app to be used in all the regions. The next program I'd like to speak about, it's called EDAN. So this is biobehavioral data, and it is used in all of the centers for a long time. And it provides for rational use of resources and for reliable results on surveillance and on the incidence among key groups of population. Also, the tablets are used, and for a very quick registration of data, and question takes a lot of time. It used to take up to 40 minutes, now up to 15 minutes, and excludes mistakes in the questionnaires. And also you can look at personal records online. There is no need to rank the records, and also there is a remote control for that, the quality of assessment, quality of collection, and we can assess the timing required. The next slide, it's the screenshot to prove my words from the database itself. The next information system, which is used successfully. Currently it's under use, and now there are some amendments that introduced. This database provides for automation of all of the processes between medical institutions, outreach workers, and the customer, improves control over coverage, and helps to track the volumes of work, as it includes NGOs. There are projects executed by international partners. So in this program we can track the contribution of all of the participants, which are the real executors. In this case, the next program is EMIO. This is online system for collection and analysis of indicators for monitoring and assessment of HIV programs in the country. In Kazakhstan, it's used since 2016. The electronic surveillance is also included, so it gives us certain results. We standardize the collection entry of data from different territories, and also in line with our norms, it's done twice a year, and also there are quarterly indicators, and in line we use that quarterly indicators for reports, and it is used in international reporting for UNAIDS report. I'm not going to give all of the details of this slide, but it's not used for the AIDS service, it's for mental health centers. So this is the center, the information for the replacement therapy. So this is the patient register for those who are on the replacement therapy, and we do continuous improvement of those systems, and also there are changes introduced into IT systems. The system that I mentioned, prevention of so the programs on prevention of the disease in key groups. So we are moving to from paper to electronic forms, and it will be integrated with the IT systems, existing IT systems. So the electronic monitoring system, which I mentioned, we will make it a cloud system. We plan to further improve the national register of population. And also there are plans to cover the whole of the Republic. And we plan to develop an IT system for pre-exposure prophylaxis because we started its implementation, and the web service for PLWH to inform the partners about their partners on the need to make the test. Thank you. I tried to be quick. Thank you, Irina. Yes, that was a really interesting presentation. That's interesting to see the electronic databases, the programs which are used in many countries. I think that would be interesting to learn something new and try to introduce this practice in your countries. The next presentation will be done by Valentina Kirzhanova, National Research Center of Psychiatry and Narcology, named after Serbsky, of the Healthcare of Russia, Healthcare Minister of Russia, on narcological trends in Russia.
Добрый день, уважаемые коллеги. Мне хотелось бы...
So, good afternoon, dear colleagues. I would like to thank the organizers of this conference for inviting me to participate in this conference. And I listened to many presentations at different sessions, and that was a great pleasure for me, and that was very useful in my work. I would like to briefly speak about the modern trends in incidence of drug addiction in Russia, the Russian Federation. Over the past 10 years, in drug addiction has major changes because of the changes of the drug market. And based on the criminal data over the past 10 years in Russia, this so-called new psychoactive drugs became more popular compared to opioids and heroin, and their share is increasing every year. Of course, we also can see that indicators of medical care for drug addiction. So this is the primary data on mental diseases related to drug addiction and drug use in teenagers, young people of 18, 19, the population from 20 to 39, and the population group of 40-59. The primary incidence reflects the situation the best for the case, for this case. So the primary incidence, so its onset was in the end of 90s. After the year 2000, there is a decrease in most of the age groups, and the general indicators for all of the age groups. The only exception is 40 till 59 year group, and they had an increase compared to 2002 and 3, so there was an increase by 2.9 times. And the general trend over the 20 years, it's a decrease of primary incidence in all of the young people's group. The high decrease rate was seen in teenagers and the young people of the age of 18-19. And the primary consultations in the older groups is growing. And with the general decrease of incidence, so there is a growing age of the patients who come for narcological care for the first time.
The downward trend is also typical for injection-based drugs. Over the past 10 years, we see the twofold decrease in the incidence and twofold incidence in primary cases. Among patients taking injection drugs, we see a decreased share of younger people and also decreasing share of the patients above 45 years old. So again, we see we see a decrease in number of patients in the age of 45 years and up. Now let's look at the structure of drug dependency depend on the type of drug. So you see that if you look at this structure, the breakdown, the opioid dependency would be prevailing and would account for almost 90%. Today, the situation is drastically different, and we see that other types of dependencies are more prevailing. Among them are psychostimulators, cannabinoids, and other types of drugs and their combinations. The latter account for 37%, and the share of patients taking opioids has decreased from 86% to 28%, and the patients with opioid dependency used to make up the largest share of all patients taking addiction drugs, not any longer. The change in the age structure had its impact on the incidence indicators. So you see that opioid dependency goes sharply down, almost to historical minimum. At the same time, the dependency from cannabinoids, psychostimulators, and other types of drugs, including the new ones, would go up. As it is well known, people that take psychoactive components belong to the group of risk when it comes to getting infected with HIV or hepatitis. So all categories of drug abusers are tested for the above-mentioned drugs, and we do 100% testing for HIV and hepatitis, regardless of the outpatient or inpatient treatment. And here you see the share of those patients that underwent treatment, and these are patients with alcohol dependency, but of course a closer, more comprehensive examination is provided for the patients that use injection drugs. The latter, as a rule, are tested several times a year, typically twice a year, especially during repeat hospitalization. And we also have information about HIV infection among drug users. The highest level is observed among the categories that take injection drugs, and lower incidence is observed among patients that take other types of drugs. And finally, let's talk about the alcohol dependency. Despite the fact that HIV level of incidence is not high among alcohol abusers, still we see the upward trend, and that is worrisome. Here I provide for you dynamics about HIV infection among patients that receive narcological treatment in hospitals, and you see here an upward trend throughout the whole period of time. And here you also see the levels of HIV infections among patients taking injection drugs, and we can see that in 78 out of 85 regions we see 5% of all users being infected, and we see that the the leaders here are Ural regions, Siberian regions, and these are the regions where drug abuse has a large prevalence and long history. And based on data from hospitals, we have high level of HIV infections, but I'm not going to dwell on that due to lack of time. What can I say about hepatitis C? The highest incidence level is observed among drug users. They are marked here with red lines. So we are talking about consumers taking injection drugs and other types of drugs. Secondly, second go the patients that take various psychotropic agents, and the third ranked the patients with alcohol abuse, and these are stable indicators of the past 10 years. The highest share of infection rate is observed among the injection drug users in 45 out of 85 regions. We have drug abusers infected with hepatitis C, and again, the worst statistics is observed in central Urals, Far Eastern regions. So we can say that the incidence of hepatitis C is high throughout the country. The level of incidence with hepatitis B among drug users is not high, especially compared to hepatitis C, and in different diagnostic categories it accounts between 2 to 6%, the highest levels observed among drug users, and namely users of injection drugs. And finally, I would like to say a few words about the impact of COVID-19. Namely, it has decreased the number of doctor visits, so we can say that the primary incidence went down by 22%, and general incidence went down by 7%. The number of visits decreased by 14% visits to doctors, and the number of hospitalizations went down by 19%. And I will make conclusions of the past years. We see a decrease in the share of young people and teenagers, but we see an increasing number of patients over 40 years of age. We see the decreasing number of patients with opioid dependency, and but we see the great dependency on new so-called designer doctors, and the growth of infection rate for other comorbidities is highest among injection drug users. We see high level of positive in tests among the drug injection users. With this, I will finish, and thank you very much for your attention. Thank you, Valentina Vasilyevna, and now I would like to the floor to Evgenia Ivanovna Kazakova, a research fellow, Research Institute of Virology, Republican Center of Epidemiology, Microbiology, and Infectious Diseases from Republic of Uzbekistan.
С докладом вирусологическая характеристика.
She will talk about viral characteristics of HIV-1 in Uzbekistan. Hello. Yes, hello. The floor is yours. Can you hear me well? Yes, we can hear you well. So, hello, dear colleagues. It's a pleasure to participate in this conference. Although I participate online, it's a pleasure to see familiar faces. And I will talk about viral characteristics of HIV-1 in the Republic of Uzbekistan. I will start from RISIDA project that allowed us to describe HIV-1 circulated strain in Uzbekistan. The project aiming at preventing the spread of this resistant strain also enjoys participation of Russian Federation, Armenia, Belarus, Azerbaijan, Kyrgyzstan, Tajikistan, and Uzbekistan. This is the second similar project being run at the moment, and this is a project that provides large-scale monitoring across the countries. And we already are holding the third monitoring across the country. As of 2016, we started doing the sequencing of HIV-1 because we have a department at one of the municipal hospitals for the patients that do not take intraretroviral therapy, but we did not, prior to that, carry out high-level surveys due to high costs, but together with UNAIDS, we ran the project, started doing it in 2014, and then in 2017 we launched the project called RISIDA, and currently we are implementing the project RISIDA 2. I would like to thank Rospotrebnadzor that is really helpful in holding this surveys. It holds trains all types of working meetings and consulting with experts. Here you see Natalia Ladness, who is one of the coordinators on the part of Rospotrebnadzor. Thank you very much for providing support to us, and also, as for the support received from Rospotrebnadzor, it was given in the form of equipment, disposable materials, equipment for the lab that helped us to stay afloat. This work was done for a long period of time, so we have developed protocols similar to WHO protocols. We have already developed and approved the second version of national protocols for the Republic of Uzbekistan, and also at our scientific facility we are monitoring several components. So we are monitoring resistance among adult patients that start taking antiretroviral therapy, and we also are following up patients that have been receiving the therapy for 9 to 15 months. And we, as I said, are continuing our project Resident 2 dedicated to cross-sectional resistance of HIV infection to treatment. So we do genotyping procedure, and we're looking at protease and reverse transcriptase. As for the incidence of medical resistance, it is quite high worldwide, but Uzbekistan started therapy not long ago, so we've been practicing antiretroviral therapy for 20 years only. Therefore, we don't have such high statistics as in countries that offered these types of therapy to their patients much earlier. We are talking about Northern Europe and Northern America and Western Europe, but we still observed several cases of mutations. So here you see data from 2015. It was a mutual project together with UNAIDS. So you saw that the initial medical resistance of HIV accounted for 2.7%. However, the patients that received treatment and demonstrated resistance, the spectrum of mutation was about 60%. So one should say that the first study included 850 patients with HIV. Residar included 714 patients from all regions of our country, and 40% of patients were naive, and while others had taken ART previously. And since we changed the tactic of our recruitment, initially we took patients that and doctors that were recommended by doctors. Then in the second study, we engaged in the all patients that started antiretroviral therapy. So we can say that over 80% of patients demonstrated suppressed viral load. That is a really very good result. However, as we assessed our results, we saw a certain increase in medicinal resistance, and the percentage was 4.8, what is lower than the threshold. However, still the growth was observed. If you look at the mutation spectrum, it has not changed. Among patients that demonstrated no response to therapy, 69% demonstrated resistance, and it's not a bad indicator, because we saw that commitment to treatment is quite high among such patients, and the level of mutation was also similar. Also, we tried to introduce the quality control for sequencing, so we did sequencing of 2 panels. We used the WHO approach, and unfortunately we don't have enough samples in order to get full quality control. So far we are working this way, and now let me tell you a few words about the genetic types. HIV circulates on the territory of Kyrgyzstan. These comparative data are between 2018 and 19, so we can see the peak of the genotype landscape. In 2015, we saw over 50% of patients that had 0.2 Hg form, while 37% of patients had A6 type. And we also saw some other minor versions. However, in 2019, A6 subtype was ranked first, so 48.5% would have that type, and the share of circulating recombinant form AG2 went down, and also we saw a large number of recombinant norms, what is quite typical for the Republic of Uzbekistan and former CIS countries. So in Uzbekistan, we have quite interesting picture when it comes to HIV subtypes, because in our country we have two different types circulating, that is subtype 06 and 02Hg, and if the patient is infected with two strains, well, if we have repeat infections, we see unique recombinant forms, and they provide us with such interesting statistics. So we can say that in Uzbekistan we have heterogenic population of H102Hg circulates here, that is typical for Central Asia region, and A6 that is typical for the Russian Federation is popular here, as well as a subtype. So we can say that 48% of the population accounts for A6, and 40.3% account for 02Hg, and there are 9% of recombinant forms. The results of the past studies are not finalized yet, and hopefully next time we will be able to produce your more detailed data, and it will be relevant for you. Thank you very much for your attention. And this is the last news from us. We finally have published our article, so now you will be able to find lots of statistics on our country. Thank you very much for your statistics. Thank you, Evgenia Ivanovna. It was very interesting, and I think that this data will be relevant for comparison, and I know that this report will be recorded, and then it will be interesting to compare data. Now I would like to give the floor to Anastasia Pokrovskaya, who will talk about the social democratic profile of people living with AIDS in our region. So the floor is given to Anastasia Pokrovskaya. So I welcome all the participants that joined us online or offline. I would like to provide you with results of a large cross-border study that took place in the 7 countries that you see on slide, and it was provided with support of Rospotrebnadzor, and many colleagues that participated in that project are here with us today, and I'm very happy about that. Well, I will dwell on the area of interest for us. For us, the goal was to create the social demographic profile of our patient, and the idea behind was to create social demographic and clinical laboratory portrait profile of the patient that receives medical aid related to HIV infection. And we understand that we are different countries, however, and the ways for pandemic spread can be different as well. So patients may have different needs, and it's important to understand what kind of patients receive aid, who do not, and who we should focus on. Here, I'm not going to give you detailed description. The survey took place for 3 years or so, and we were able to include over 12,000 patients into this study. The number of patients per country were calculated depending on the number of HIV positive people, and of course here the figures would differ substantially. So we collected standard information from medical documents, and we also looked at social data on the patients, their marital status, the number of children, if any, that they had, and other types of information that we could collect on the patient. All in all, you can see we have collected or have developed almost 70 indicators, and I will dwell on something what is of particular interest. As it was said during previous presentations, the main category of patients are men, as you can see here. So the first bar stands for man, and the second for women, and second for men. And we know that those who receive medical aid and are ready to participate in surveys are women, and therefore the higher proportion here are women. Another important point we paid attention to.
So it is in line with the general information about this data. So the women were younger in the study, and about men, we know that in our region. In women we find it earlier. On one hand, they are infected at earlier age. On the other hand, they are detected earlier compared to men because they have more access to medical services. And the difference between men and women, and here for men and women, this is the total for the 7 countries. And the compliance was better for women compared to men. If we look at the split by country, so this is the same for all of the countries. And for Belarus, men had better indicators, better results for compliance, but it can be due to different reasons, because women also were prescribed medication because of vertical transmission risks. And after thinking about this, we understood that was not gender related, but it was related to other social factors. And also related to differences in behavior between men and women. So these are the main transmission and infection ways. So mainly in our country, these are the drug users, and in our region, most of them are men. If we look at the people in the study, those were mostly people with sexual transmission. Unfortunately, we can conclude that the drug users are less covered compared to those with the sexual transmission. If we look at the responses about oral drugs over the past 6 months in some of these countries, so there were many such people. And we can say that drug consumption is no impediment to get medical care, but still this is a risk group for further transmission of HIV infection if these patients are not on the treatment actively, they are not getting it. Another thing that we noticed, and which may have a potential impact on compliance and accessibility, is the labor status. Most of our patients, they work, they continue to be active members of the society, and there was interesting group people who mentioned that they work in another country, not in the country of their origin. So these are labor migrants. It varies from country to country. In Tajikistan, Uzbekistan and Armenia, there was a big share of people that mentioned this type of labor activity. And we understand that there are much more such people because they have limited access to medical services in their country, and when they are abroad, so they cannot always get treatment for HIV, and also for accessibility and risks of transmission of infection. So this important group, most labor migrants are men, which is also reflected in those indicators that we can see here in terms of coverage of men and women medical services. The marital status we also assessed it. As for epidemiology, premarital relations, well, they are not always mentioned, and they do not always speak about the real sexual behavior that is important to us. So we pay attention to the number of sexual partners, especially relations that our patients have. We saw that there are lots of people who mentioned they had more than one sexual partner over the past 6 months. So potentially they may be in the group of in the risk group. And also among those who mentioned that they have a constant sexual partner, only 1/3 of them had HIV-infected partners, and many mentioned that their sexual partner has no HIV, and here no data is in gray, so they don't know about the status. So, and also we need to just involve partners to be tested. We cannot earlier make prevention or treatment because non-infected and partners, and also partners with no status, they can have a major impact on the infection rates. Well, children, so this is the participation in demography. Most patients, we understand that our patients are quite young and they already had children, may have children in the future. As for the country's indicators, and in some children, we have 4 more children. And what is the most important detail for us, if we look not at the number of children but number of births that women mentioned before the diagnosis of HIV and after the diagnosis. Most children were born by women before HIV diagnosis. We cannot say that it was due to HIV. I mean, the decision not to have more children, maybe they just already have enough. Anyway, they were not planning them. And the young women, they were just under 35. Maybe they were going to plan to have more children, but that is actually the trend that we saw, the reproductive trend. Well, summarizing today's presentation, what we can say about the results of our studies. So women compared to men in the countries that we studied have higher compliance to follow-up and treatment. They had higher efficacy of treatment, and we should pay more attention to the patients for men, especially who use injection drugs, as they may be limited in terms of access to medical care due to different reasons. And also migration processes and account for a big share of our patients. Many of them participate in migration, can have an impact on transmission of HIV, on accessibility of medical care for these groups. And patients who are followed up in medical institutions, who have access to medical care, they preserve their social functions, they participate in labor activities and demographic activities. And of course, we should just try and also support their quality of life and prolong it. And possibly HIV has a negative impact on reproductive choice of women. And because of that, we should also pay special attention to that. And we should remember that many of our patients, they have HIV negative and with a known HIV status. And we should also pay attention to that. We should provide consultation to the patients and to their partners. And also, we should start ART with preventative goals in these groups of patients. Thank you for your attention. Thank you very much, Anastasia. Thank you for such an interesting study. Next presentation will be done by Aygul Salpuyeva, head of Department of Virology of the Republic Aid Center of Kyrgyzstan, experience of HIV rapid testing systems in Kyrgyzstan. So good afternoon, dear colleagues, dear participants of the conference. I would like to thank the organizers of the conference for the invitation. I'm very happy I am here at this conference, and I would like to share the experience of rapid testing, HIV rapid testing in Kyrgyzstan. And I would like to speak about the assumptions and to introduce the rapid testing and what were the reasons, what were the learnings, and what were the next steps. Well, so in the first place, we're talking about the recommendations of the European WHO mission. That was in April 2011, our republic. There was assessment of the state program for HIV/AIDS in our country and other activities aimed at fight against the pandemic in our country. And they made several comments, and we used two major recommendations. First, to develop and suggest amendments to the legal and to the norms and regulations, and also allow for NGO participations and HIV testing and consultations and preparation of specialists in line with the rules for consultations and testing by their certification. And so consider the participation of non-medical staff and public society in provision of services for testing and consultation on HIV, so that we can foster rapid testing, rapid HIV testing. And also first we analyzed coverage of HIV testing from 2008 till 2010, and also by ways of transmission. So according to HIV testing coverage, so we found out that we did over 400,000 tests per year, and among them the share of key groups was very small, and who were tested: pregnant women, medical workers, which is obligatory, and military people, labor migrants when they need the health certificate, and other groups of population. The share of key population group was less than 1%. And also when we analyzed the new cases of HIV, we had about 60% of new cases coming from the key groups. Sex workers, people use injection drugs, and men practice sex with men. And also in 57% of cases that was oral, that was the injection drugs. And you see that in 2008, 9, and 10, you see the shares of these key groups in the total amount of people tested, less than 1%. Introduction of rapid tests for HIV in NGOs. That was the solution to this problem. I would like to speak about advantages of rapid tests. Quick access to test results, and also when we introduced that practice in NGOs, we gave access through these organizations to vulnerable groups, key population groups, because at their own will they do not wish to come to a medical institution to be tested. And also consultation before and after tests to these key groups of population in the environment where they are getting their services, customer-oriented environment in NGOs. The rapid test for HIV in NGO helped us to decrease the workload for the AIDS labs.
Постановки экспресс-теста по околодистевой жидкости.
And also the technique is very simple.
Очень удобно в использовании человеку, который...
It's very easy to use for the person who's providing the service, and it's very easy for the person who gets the test done. Well, how we implemented the rapid test in 2012, based on these recommendations, we decided to introduce rapid tests in 12 centers. 12 centers. NGOs. So they worked with these three key groups: sex workers, men having sex with men, and people who consume injection drugs. And 3 organizations, they work with sex workers, and 3 with men having sex with men, and 6 working with drug users of injection drugs. And we also took into account that in case of positive result, so this result should be proved in 8 centers.
Тренинги трехдневные именно сотрудников центра СПИД для того.
And also we provided for interaction between NGOs and 8 centers. And 6 months after introduction, we made an assessment of the program. And as of this assessment, it was decided to expand the rapid test system. And in 2013, by the decree of the Healthcare Ministry, there was the official permission given to introduce the tests in 21 NGO. 21 NGO, they are working. They have their own websites, around 27, 28 websites, and in 2013. And also we introduced that type of rapid tests in prison. So, and if this liver test is positive, so then the blood assay is done, and it's done this test in the AIDS center. We also developed the forms of reports to understand what will be the next actions, next steps. That was pilot. In the beginning, when we introduced the test at the NGOs, so that the customers, they get used to that, there was a reward, mobile units. So for the mobile cards, maybe because of that, many customers could get the secondary tests in NGOs, and even the NPO clients, which were positive, even under ART, undergoing NRT, because of the rewards, they also could take the test. And also, we did not fully develop the mechanism of follow-up for those with positive results. So in the beginning of the project, we would lose the clients. Not everybody agreed to get the support, and they were recommended to go to 8 centers to prove their positive results. And they had some problems in the beginning, and also there were cases of unquality consultations, and maybe sometimes the express tests were not done properly and the results were false. And then we took into account all of these details, and at a regular basis we do monitoring with our partners. The rapid HIV tests are currently done.
Как я сказала, 21 НПО, это
by 21 NGOs, so these are different projects. Physiatry, that was the flagship. Now the EPID program on ICAP website, we do rapid tests in mobile stations in faraway regions of the Republic. At the same time for syphilis and the hepatitis B and C.
продолжается.
Here on the slides, you see the results of express testing on NGO-based. That is something that is funded by the Global Fund. And here you can see the statistics from 2016 to 2020. And here you see the positive results as absolute number. And these are the newly identified cases. Here you see the express testing based by NGO projects within the Flagman project, and again statistics for the same period. And here you can see that Flagman project provided the greatest number of new HIV infections because they had different approach to testing. And as I said, case management here was very thorough because new clients were tested, and case management was so good and efficient that measures that would follow up the positive patients, they would not have any motivational any incentive bonus until the patient would get viral suppression. This is the express testing with GSAN facilities. These are the express tests that were done within ICAP projects. They did testing based on capillary blood and mucosa. And here you see the new cases of HIV infections based on risk groups. I would like to show you that we still see new registered cases among the key groups of society, and thanks to the introduction of express tested within NGO groups as of 2019, we were able to find an approach to one group, precisely men practicing sex with men. And in absolute numbers, you see that before 2019, we had very few cases of HIV infection registered within that category, and from 2019 the identification rate went upward. And thanks to introducing this program, we have enjoyed considerable success. And as for epidemiological situation for HIV, the situation is the following. As of January 1st, 2021, we have carried out cascade. Unfortunately, our country was not able to achieve 90-90-90 goals, and we have what we have. And as for our subsequent steps, we have taken some lessons learned once we have introduced the system and regular monitoring. So we will continue express testing with mandatory monitoring on the part of Republican AIDS Center. That will be done together with our partners. So we will continue express testing with engagement of NGOs, and we also will do it with the use of the mobile unit, and we will also do express testing at locations with the high traffic of people during some special events, and we will extend express testing in medical facilities. And in March 2021, we held trainings for nurses in hospitals, so they would be capable to test patients based on clinical indications, especially in those locations where there are no immediate access to labs. And we will also encourage self-testing among discordant couples, and we will assist testing against the background of COVID. And We also continue index testing, and we will introduce assistant testing for NGOs, and we will continue regular education for medical professionals, for NGO workers, and we will also offer so-called refresh trainings. Thank you very much for your attention. I was really in a rush. Well, thank you very much. Thank you for this interesting report. And now I would like to give the floor to Olga Pantilevna, Head Department of Epidemiology and Medical Statistics from St. Petersburg HIV, AIDS and Infectious Diseases Center. She will talk about HIV epidemiological situation in St. Petersburg.
Здравствуйте, уважаемые коллеги.
Hello, dear colleagues. Allow me to share with you our achievements and our plans for the future. St. Petersburg is one of the regions that counteracted HIV infection among one of the first, and only since 2013 St. Pete is not among top 20 cities in terms of incidence, and up to that we were among top 20. Well, as for 2020 or 2021, we will again improve our rating, and we hope that the situation will continue improving. As of 2012, we have better statistics than that, the average of Russia. As of 2006, we see a downward trend in terms of detecting new cases, although that in absolute numbers statistics is still quite high. You can see that on the slide. Regularly we identify 2,000 cases on our territory. That includes permanent citizens and visitors, and generally we identify 15 to 17 cases among children, and this is explained by different ways of getting infection, but that all happens against the increasing number of the patients that undergo testing. The only difference was in 2020 when we had to impose restrictions in terms of visits to outpatient clinics. So the number of examined people in 2020 went down, and that includes local and foreign citizens. So the coverage overall in the last year went down. If you look at the trend, we've been tracking it for a long time, and we believe that the overall trend goes down, and annually we identify fewer and fewer cases. We are still concerned about a high number of people that are not permanent residents of our city. In 2020, we had 42% among all patients who were foreigners. It's a large indicator, I believe, one of the largest in the Russian Federation. If we look at the incidence dynamics and do the breakdown for the age groups, we should say that over the past 5 years, we see improving statistics for all age groups. It is important to say that the incidence is higher among older people of older age, and maximum incidence would fall on the age group between 40 to 49 years. If you look at this graph, you will see that the incidence is prevalent among men except for the age group of 20 to 24 years. And here the highest incidence is between the age of 30 to 45 years. With women, the statistics is more homogeneous, and there is not huge difference from one age group to the other. If you look again at the statistics, you will see that overall we have twice as many male patients that have a positive HIV infection than women, and women have higher incidence in the younger age group between 25 to 39 years. Again, here you see the same statistics but shown graphically. So the last year showed better statistics than the previous one, and we can say that most of HIV-infected people that live in our city belong to the age group of 35 to 50 years. If we look at ways of transmission, we see two typical trends. And if in 1999 the dominant way of transmission was parental. Then it became from 2013 sexual way of transmission became dominant, and something what was quite typical. But now in 2020 again the trend changes. Parental becomes more popular, and sexual transmission on the contrary goes down. So in 2020, if you look at absolute figures and structures and ways of identification, I think here the statistics is in line for the line with the average across the country, but we have two rare ways of transmissions, and that is the infection or transmission of infection to infants during breastfeeding, and also transmitting infection to children that did not have any sexual contact. So surprising, but something we have to pay attention to. We have a large number of HIV positive people that are registered and that receive antiretroviral therapy. If you look at the coverage of the letter for the past year, the coverage was high, and it was equal to 68.7%. So if you look at our performance, important is to say that we have a decrease in number of lethal outcomes, and in that regard 2 years show positive dynamics, and despite all changes and pandemic, we see steady increase in the number of lethal outcomes caused by AIDS or development of HIV infection. We believe that the largest impact is provided by continuous antiretroviral therapy that shows high level of efficiency, and as for lethal outcomes, we know that 24% that die in our region, they are not registered and are not followed up. Therefore, they are not treated, and they are not citizens of our region. That's why they probably are reluctant to seek medical aid. So we believe that overall the situation in our city is quite good. If we were the leaders in terms of the number of identified cases, we reversed the statistics, and we have steady increase over a long period of time, and we're talking about 5-year period of time. And out of problems that we have identified for ourselves, coronavirus infection in this regard does not count, because we believe that it does not have large impact on all processes that are taking place. So there are 3 core problems, and that is a large load on AIDS center. After all, again, 42% of newly registered cases are not citizens of St. Pete, and 51% of patients that approached us were citizens of other regions, and they were monitored in different regions previously. Another big problem,
and it caused lots of concern. So this is the share of the transmission way through injections, and also it is connected with the high inflow of people from other regions with higher rates of drug users, and also HIV can be transmitted through breastfeeding and family transmission. And so it's these are the cases of the places of residence where there are people who are not treated with ART. Thank you for your attention, dear colleagues. I tried to make it as fast as I could. Thank you very much, Olga. Well, as the last speaker did not appear, we may say that we practically finished on time. If somebody has some questions, so 1 or 2 minutes we do have for Q&A. As far as I understand, there are no questions. I would like to thank all of the speakers. Yes. I would like to still ask one question to Kyrgyzstan. This is very relevant about rapid test system. Why you have such low level of incidence during the express test? I did not understand about the groups, but you showed one big group, 20,000 tests, and 0.1 HIV infections you found. So what is the share of what is the share of rapid tests in the total number of HIV tests? Sometimes the routine tests, well, the share of new cases, and less than 1% of all of the people tested in the Republic. What you say among the tested in the NGOs, right? You ask about that. Yes, in the beginning, we had quite good indicators, but starting from the year 2013, we see that we have like 20,000 and so on, and these are the numbers of tests, and incidence is smaller. Maybe we've identified all of them, but among sex workers we also witnessed that, and among men having sex with men, I would think that sex workers, they're in the general group of the population, but not everyone can accept that they are doing sex work. And despite the big number of tested even in the NGOs among them, so the share is small, their share is small, and I think this type of rapid test gave us access to key groups of the population, and they have this compliance to testing. They started to get used to regular tests, and despite having less and less new cases, and we think this is also an achievement. They know that you should get the test, and they get this prevention services, prevention treatment. It's like stimulation. The share is like small. Yes, those who did the test with the rapid test. In 2016, among the new cases, we had the biggest number. It was 30%. Of the total number was among the key groups of population for the flagship or flagman project. They had a different approach to that. That's it. Thank you very much. Thank you. I would like to thank all of the speakers for exciting presentations, for sticking to your timing. That is very nice. I hope that we will have time to have a cup of tea. I would like to wish you fruitful work in 2021 and in the next years in terms of prevention of HIV and in terms of achievement of the ambitious goals set by UNAIDS for the next future. And I hope that that's going to be our overall goal, and we'll do all we can to deliver that. Thank you.